Thank you. Good evening to everyone here tonight. I'm Carol Jenkins, Executive Director with Cystic Fibrosis Research Incorporated, and welcome to all of you to our Cystic Fibrosis Discovery Series. This series was developed in collaboration with Camille Wasowich, who is a nurse practitioner at Stanford in the adult clinic. Together, we've created a program to make information available to everyone, not only those here present tonight, but those of you who are streaming online and others who will tap this information at a later date. As always, we urge you to work with your health team for your medical treatment. This is not intended to be used for patient's diagnosis or treatment, but to be used in consultation with your adult or pediatric healthcare team. Tonight, we're looking forward to our presentation on managing pain, different alternatives available to all of us. Thanks to Genentech and AMED Healthcare for supporting this important evening. Their support pays for the venue and the refreshments, as well as this studio we've constructed here at the Crowne Plaza Hotel in Palo Alto, and any other costs associated with the program. Tonight's program is being filmed by David Suhu. Volunteer Eric Martin is handling the streaming portion of the production, and staff member Joanne Davis is tracking questions from our online participants. Many thanks to Scott Wakefield for his guidance. We are live at Crowne Plaza in Palo Alto. I encourage you all to ask questions, whether you're here or online. A special shout out to those of you who may be in the hospital. We're so glad that you can join us. Finally, thanks to our volunteers for serving food and helping us with our cross-infection policies. And now I turn this over to Camille.
Good evening and welcome. Thanks for joining us, those here locally as well as those by remote. Certainly those in the hospital, we are sad that you're not with us, but glad that you're joining us in spirit. It's my privilege to have worked with Tracy, as well as having met her in several leadership positions at Stanford. She's worked at Stanford in pain management for the past 7 years. She got her graduate degree at UCSF and her undergraduate at USF. She is not only an expert in pain management, as well as, I think, organization and just being a fabulous person. So with no further ado, I'd like you to welcome Tracy Malik, who will be discussing pain management and strategies in cystic fibrosis tonight.
Thank you, Camille, and thank you for having me. So I'm Tracy Malik-Searle. I am the Senior Nurse Practitioner in the Department of Pain Management at Stanford University Medical Center, and I want to thank you all for coming out tonight for this next edition of the Cystic Fibrosis Discovery Series. We're going to be talking tonight about pain management and the different therapies that you can utilize to help manage your pain. Having technical difficulties here. Okay, there we go. So I wanted to first just give an overview, a little bit of the epidemiology of cystic fibrosis before we go any further. So as you may know, cystic fibrosis is an autosomal recessive disease. And what that essentially means is that if you have both parents that are carriers of the gene, an individual will have a 25% chance of inheriting the disease. 2 to 5% of Caucasians worldwide are carriers of the gene. So that equates to about 1 in every 3,000 live births in Caucasians. The incidence is a little bit less in African Americans, and it's rarely found in the Native American, Native African, or Asian populations. In the late 1930s, it was very rare to survive this disease beyond infancy. And then a relatively short 50 years later, we see the average median survival up into the 40s and beyond. The literature that I saw tells me that about 80% of those with cystic fibrosis actually reach adulthood. So that being said, as people are living longer, the likelihood that they're going to come up across pain, acute and chronic, is very likely. And this is even more likely in folks that suffer from chronic disease, cystic fibrosis being definitely a chronic disease state. So the learning points that I'd like to get across for you today is to help you identify the reasons for your pain. Why is pain unique in this patient population? And what are some of the unique techniques that you can utilize to manage your pain? We're going to spend a good deal of time tonight talking about the use of medications, the different types of medications, and how best to utilize them. Treatments beyond medications. And then I'd like you to be able to, after the talk this evening, do a self-assessment and figure how you're going to be able to control your pain, manage your pain, and not let your chronic disease or your pain manage you overall. So when I think of cystic fibrosis and the top complaints of pain that patients experience, I always think of chest pain or pulmonary pain. So if you look at the two images on the screen now, the one on the far right being a normal chest x-ray, and the one on the left, or next to it, being a chest x-ray of a patient with cystic fibrosis, just by looking at these images, you can understand why patients suffer from chest pain or pleuritic pain. By very nature of the chronic infection in cystic fibrosis patients, the lung scarring and the atelectasis that's a result, chronic cough, chronic inflammation, overuse of accessory and intercostal muscles, you get a lot of neuropathic pain, but you also get a lot of musculoskeletal pain and overuse pain.
What is accessory and intercostal muscles and atelectasis?
So atelectasis is an inability for the lung to fully inflate. And intercostal and accessory muscles are essentially the muscles that surround the lung and the diaphragm and allow you to ventilate, essentially, take deep breaths. So a second chronic complaint of folks with cystic fibrosis is abdominal pain, gut pain, stomach pain. And if you look at the primary disease process and how it affects some of the internal organs and what patients, particularly later in life, suffer from, gallbladder disease, pancreatitis, liver disease, constipation, either related to distal intestinal obstruction or constipation related to medications that you have to take, you can understand why patients complain of a lot of GI symptoms, gastrointestinal symptoms. And then finally, musculoskeletal and bone pain. So I hear a lot from patients that their body hurts. They hurt all over. They have a lot of muscle pains. They have a lot of joint pains. It's not necessarily unique to the cystic fibrosis population, but it is unique to those over 20. And as we mentioned, we're seeing a lot of the cystic fibrosis patients advancing in years. And so it's a typical complaint that we see. Chronic low back pain probably being almost 90% of primary care doctors' visits to date. And then you add upon that the dysmotility, the immobility, the chronic disease state of patients with cystic fibrosis, and you can understand why they have a lot of musculoskeletal complaints. I put this slide up titled, "Why Am I So Depressed?" in correlation with a chronic pain talk. Because it's incredibly important to understand how the mind and the body interact together. And how when you're looking at a chronic disease state, chronic pain being chronic disease state, that when you're feeling down, you're feeling depressed, your ability to be able to manage your pain or your chronic disease state is at a much lower level. And so understanding in patients with chronic disease that there is a component to depression associated with the long-term chronic disease. With cystic fibrosis in general, decreased life expectancy, realizing that you're going to potentially not live, beyond your fourth decade of life. The ability for you to not be in control of your life or be in control of your disease, the unknown associated with it, and then just coming to terms with your own mortality. So what are some of the reversible causes of pain in this patient population? And how can we talk about primary prevention to help reduce a chronic pain situation? So the chest pain that we talked about, how can we work to optimize the patient's regular chest physiotherapy? How can we be real cognizant of identifying infection right away and then treatment of that infection to reduce the chronic inflammatory state that could result in the chronic chest pain? For the gastrointestinal symptoms, really focusing on regulation of blood glucose if, in fact, the patient's got a pancreatic problem or a diabetic problem, correcting pancreatic insufficiency, diet regulation, good bowel hygiene, replacement of vitamin deficiencies. And for the musculoskeletal, it's simply a matter of keeping active. Getting out of bed on a daily basis, pacing of your activities, not running a marathon like this little dog is about to do, daily stretching, massage. So when I think of pain management, I really like to put it into 4 different paradigms. And I utilize these paradigms interchangeably. Some I will use on a more chronic, ongoing basis. Some I will use intermittently as symptoms flare. And sometimes I'll utilize all 4 of the paradigms. Paradigms being specifically the use of medications, the use of interventions or procedures, behavioral modification, and then complementary treatments. I'm going to talk about each of these paradigms in depth, but this was just a nice way to present them to you. We'll start by talking about medications. Non-steroidal anti-inflammatories, over-the-counter ibuprofen, Advil, prescription strength anti-inflammatories such as naproxen, naproxen, and simple Tylenol. In about 50% of patients, this is all that suffices in terms of management for their musculoskeletal complaints. And patients do really well. So as long as a patient doesn't have a primary kidney problem or liver problem, the use of non-steroidal anti-inflammatories, as simple as over-the-counter ibuprofen and Tylenol, might be all that's needed.
Would you worry about the patients because a lot of them are hypercoagulable with distended INRs? Would you worry about non-steroidal and move more towards Tylenol as an option to prevent hemoptysis?
Definitely. So if that happens to be a particular situation in a patient, I think that it's very important that they speak to their primary care doctor or their primary treating physician, be it their pulmonologist, about their risks of taking the nonsteroidals, because there definitely are contraindications to that. We're fortunate in that we do have a nonsteroidal anti-inflammatory that shouldn't have an effect on coagulation, and that's Celebrex, a COX-2 inhibitor. So there still are options, but that's a very good point. Was there another question in the back of the audience?
Excuse me.
Yes.
Just not sure.
It's picking up.
We lost some audio. Let's try this. Did you just listen? Try it.
Okay.
Is that picking up? We lost the audio.
That's not good. Let me go back to my little walking dog.
Did we lose the audio with regards to taping or just streaming?
Both.
Should I go get on tape?
Well, can you speak into the mic just
Testing, 1, 2, 3, testing. Testing, 1, 2, 3.
Yes, we're getting something here.
Should I just stand a little closer to the microphone?
Talk louder.
Talk louder.
Testing, testing.
Scott says the wireless mic transmits on a different frequency from the first one.
That's it? Okay. Let's, the battery's still strong.
It is?
Yeah.
Yeah, we're getting a signal, it's just not going through.
The supporters of this program, who in most instances is right here, is himself the father of someone with CF, and he's working with us now from DC.
Oh, wow. You gotta love IT, but then at the same token.
And then Tracy, they're
Mhm.
asking if you could repeat the question again when we get back on.
Yes.
Questions.
Okay.
And my question in advance is,
Yeah.
you're using the word non-steroidal, is that to say a non-steroid
Yes.
drug? Being
Yes.
the voice of the layperson.
Yes.
I wanted to make sure that everybody was just tuned into that word.
Yes.
Yeah, no story when they say Motrin, because some of these,
No, I know.
some of them are really smart.
Yeah. Are we live if I talk? I mean, is this going to be recorded?
Yeah, we have audio again, so start podcasting.
Okay.
Don't give us your business.
And we're back.
Okay, welcome back. So, sorry for that brief interruption there. We're going to start over and just talk about medications because I think that this is a very important part of the treatment of chronic pain. Definitely not the only way that we utilize managing chronic and acute pain, but actually a very big component and one that most of the viewers in the audience and at home are probably familiar with. So the first line of medications that I will typically recommend for anyone with musculoskeletal pain would be a nonsteroidal anti-inflammatory medication, such as ibuprofen or Motrin over the counter. There's also prescription strength anti-inflammatories, and those examples of those are naproxen or naproxen, and then the use of Tylenol. As a very effective analgesic agent, something that will help with musculoskeletal pain. So there was a question in the audience earlier about the use of the nonsteroidal anti-inflammatory medications, which do have a side effect of bleeding in patients that already have a primary bleeding disorder or are at risk for bleeding, and or have had hepnoptosis in the past. So being a very classic reason for bleeding in patients with cystic fibrosis. And my recommendation is that you discuss this with your primary care doctor or your primary treating physician because any medication that could potentiate bleeding, be it aspirin, ibuprofen, Motrin, could be very dangerous to anyone with a bleeding disorder, particularly if it's bleeding into the lungs. Was there another question? I don't think so. Okay. So very powerful medications, a great place to start. And as long as somebody doesn't have a bleeding disorder, doesn't have hemoptysis concerns, doesn't have kidney disorder that they know about, or liver disorder that they know about, these are very safe medications to use. My caveat to the medications before we go any further is that all medication usage should be done in strict consultation with your primary care doctor because they are going to know the best, or your pulmonologist, whoever winds up taking care of your pain on the primary basis, will be able to judge what medications that you're on now and better able to guide you in the safe use. So the second category of medications are the topical analgesics. So these are medications that you would apply to your skin, particularly to the point of the body that hurts, and not have to swallow a medication if you have a lot of gastrointestinal symptoms or stomach issues. So topical analgesics, non-pharmaceuticals, non-medications, simple ice and or heat to areas of painful muscles or muscle spasm can be quite effective. Prescription topical analgesics, lidocaine, local anesthetic. It's a medication that the dentist will inject into your gums before dental surgery. It's what the surgeon will inject into your skin before they do the first surgical cut. Very effective at relieving pain. And so the manufacturers of this product have formulated a topical applicant, something you can put actually on your skin to help with localized pain. And it's called Lidoderm. And you can talk to your doctor about that. There are other topical analgesics. One in particular is called Flector patch, and it is a non-steroidal anti-inflammatory medication. It's used for inflammatory pain, and again, it's topically applied. So if for some reason you can't take an oral anti-inflammatory medication, it's a nice substitute. Antineuropathics. That's a big word. What does that mean? Well, that's essentially